joined us via Zoom, and we have several who are joining us now as this meeting is being streamed live on Facebook. So hello to the Facebook universe. I'm Stacy Abeles. I am the Director of Development at Petal the Cause, and I am pleased to welcome you all today to our panel presentation on COVID and cancer. Are we making progress? I am joined by a very esteemed panel of friends of Petal the Cause that I'd like to introduce now, and then we'll go ahead and get started. Just some housekeeping notes. This will be recorded live for posterity and available on social media after this event. If you do have any questions, feel free to put them in the chat box, and we will try to keep an eye on those as the presentation moves along and find an appropriate place to insert them or answer them at the end. We will also have a Q&A at the close of the session, so you can also feel free to hold your questions until the end of the presentation. So let me go ahead and start by introducing today's panelists. We have a few on the screen, and we will have one that will be joining us shortly. So to start, we have Dr. Ryan Fields, who is the Professor of Surgery and Surgical Oncology at the Washington University School of Medicine. Hello. Dr. John DiPergio, who's the Deputy Director of the Alvin J. Siteman Cancer Center and an endowed Professor of Oncology, also the Chief in the Division of Oncology at the Washington University School of Medicine. Hello, Dr. DiPergio.
Hello. Hello.
I see, and wow, appropriately timed, just as I'm prepared to introduce her, we have joining us just now, Catherine Glover Collins, who is the Assistant Professor of Breast Surgical Oncology in the section of Endocrine and Oncologic Surgery. Wow, that's a mouthful, Dr. Collins, at the Washington University School of Medicine, just completed with clinics. So thank you for joining us this afternoon.
Thank you for having me.
And certainly last but not least, we have Dr. Amy James, who is a Professor of Surgery in the Division of Public Health Sciences at the Washington University School of Medicine. Hello, Dr. James. I know you're saying hi, you're on mute. Hi, how are you? Okay, so again, this is being recorded live, so we just kind of keep it moving with technology. So again, if you have any questions along the way, the chat box is available to you, as well as we will have some opportunity to ask some questions along the way. So let's start off with you, Dr. DiPergio. What do we know now about COVID that we didn't know when we last brought this group together in May? What's changed? What are the big emerging news coming out of the coronavirus story?
Well, I'd have to say that what we know today is that number one, most patients that get the disease are minimally symptomatic, and many are asymptomatic. Number two is that many people who develop an infection actually develop immunity now, I think, that is longer lasting than we initially thought. And number three is that we realized, even though there were some bumps initially with the care of cancer patients, that we could effectively and safely see cancer patients at the same rate and with the same level of expertise that we did before COVID without any risk to the patient. So I think that's the most important thing, that there was a lot of unknowns initially and that we were afraid, justifiably so, about the unknown. Now we know a lot more about the disease, and I think that we've been able to really alter our method of care so that we can see patients very safely. I tell everyone that it's safer here seeing a patient in Siteman than it is walking around the street.
It's probably true. Okay, thank you. Dr. James, moving to you. We've noticed in St. Louis City and St. Louis County, as well as many other metropolitan areas across the country, that restrictions are tightening. Why is that, and what has changed in these past few months?
So I think a lot has changed in that respect, and that we had that strict lockdown and we saw our rates start to drop. And once we started to open up, everything started creeping up back again. And if you're watching the news, which I know not everyone wants to watch those numbers every day, you can see that our case numbers went up. We became concerned about what we call the positivity rate, which is the number of positive tests based on how many tests are administered. And then we watch what our hospitalizations look like. And we saw those start to inch up. As we start to increase restrictions again, we're going to start to see our cases drop as people are wearing masks and social distancing. And I think it's going to be, you know, no one has a crystal ball, but I think what we're going to see is a little bit of tightening and relaxing and tightening and relaxing until we get a pattern developed and can really tamp down the COVID. So, you know, wearing a mask, staying socially distant, being physically distant, not necessarily socially distant, but you know, being careful is still really important so that we can keep infections under control.
And would you agree that probably a lot of the decisions from the school districts have a lot to do with that at this time?
You know, that is another, if we had a crystal ball and could tell what was going to happen, but I think the school districts and the colleges and universities have been thinking very carefully about how we, you know, look out for the welfare of students and families and the potential risks of bringing large numbers of people, regardless of their age, together.
Absolutely. Thank you. So we've heard that COVID has slowed in its diagnosis numbers and that treatment for unrelated conditions are down, mostly due to people voluntarily staying away from hospitals and clinics. Dr. Fields, how do you feel this has impacted the diagnosis rates for those with a cancer diagnosis?
Oh, well, I think what we've seen, and this sort of echoes what Dr. DiPerzio had said to start out, is, you know, I think we feel confident now bringing people into the medical center, into the cancer center for their treatment, but also for screening and things like colonoscopies and skin checks for skin cancer that we just weren't doing in April, May per se. So I think what we're seeing is that a lot of people may have deferred some of those more elective screens and visits, which may have not been by choice, meaning the colonoscopy labs were essentially shut down while we were trying to figure out what was going on with this virus. So we may see a little bit of a delay in diagnosis of some of these cancers, and whether that is clinically meaningful or not is what people are trying to decide, meaning there's a couple month delay would have changed an early stage cancer to a later stage cancer. Anecdotally, from my practice, I take care of a lot of patients with skin cancer that are usually referred by dermatologists, and a lot of the dermatology offices were closed for several months. So the types of cancer we were seeing during the early part of COVID tended to be more symptomatic or larger cancers that wouldn't be caught by a dermatologist, but a patient would know it because they had something that was painful or bleeding or something like that. And now that the dermatologists are reopened and that it's the summertime, we're seeing sort of a rebound effect of a lot of people coming in with new cancer diagnoses that are now being seen in the office. So it's resulting in a large volume of patients now to sort of catch up with that. And I think we may see that across the board, but I think the take-home message for now is, you know, if we sort of go back to when this started, people were, you know, wiping down their cardboard boxes from Amazon and bleaching their groceries sort of things. And I think we know that that was probably a bit overboard, but back then we just didn't know. Similar, we had a lot of the offices closed, but to echo Dr. DiPerzio's comments, I think we now know it's pretty safe to come into the medical center where you're being screened and the employees are being screened and people are wearing masks. And I'd agree, it's safer here than it is at a restaurant to come to the doctor's office with all the precautions.
Thank you. And so, Dr. Clover Collins, as I move to you and we kind of speak about people going into the doctor's office, what do you recommend to people who need to seek medical attention for something that has maybe recently emerged and or who are due for regular screening, like a mammogram, but who might still have fears and be afraid to go in for an in-person appointment, or who maybe have family who are concerned about them going to an in-person appointment?
Well, you know, basically we have to encourage these patients to seek their treatment. I think one of the things that has been borne out is that the masking does work. You know, you had that case of the hairdressers in Springfield, I think it was, where they treated 100 patients and 2 of those hairdressers were COVID positive. And none of those patients or none of those customers got sick with COVID because the COVID patients were wearing the mask and the customers were wearing a mask. The transmission from, if both people are wearing a mask, the transmission rate of COVID is less than 1%. It's like 0.3. And so masking is very important. I think social distancing or physical distancing when it's possible is also important. And, you know, taking on your responsibility on yourself. If you have symptoms, if you're around people who have symptoms, then don't come out. But other than that, I have to echo what Dr. DiPerzio and Dr. Fields are saying. You know, the medical center is a very, very safe place to be.
Thank you very much. So Dr. DiPerzio, moving to you and speaking about treatment related to cancer, how, if at all, has treatment or the consultation process changed at Siteman for patients, caregivers, and their families, and what has been the response to those changes?
Yeah, that's a very good question. You know, there's been a lot of controversy and disagreement about how we should actually manage new patients. So for the most conservative among us, I think that everyone was convinced that a patient should come alone and be hospitalized by themselves. I think that what I can say and what I'm happy to say is that the physicians at WashU and at Barnes Jewish Hospital have been some of the strongest advocates for patient family collaboration engagement with their care, so that we've now have visiting policies for our COVID patients. So patients are not going to be stuck in the hospital alone, generally speaking, which is a big plus. You know, family members, I always say that they're the best healthcare providers in the world, in the hospital or out of the hospital. And so we need those family members engaged. I mean, we have to be sensible, and there has to be masking and distancing. And also in clinic for quite some time, there was some push on the school to actually have no family members attend new consultations. And we actually vehemently oppose that, because we understand that family members are very critical to a patient's correct understanding of their diagnosis and treatment. And oftentimes a patient will leave a doctor's office for that first visit and say, oh my gosh, I know I have cancer, but what did the doctor say? And so you need the family members. So we've been able to maintain that. That's been critical. So I would say that generally speaking at Siteman, the general care right now of cancer patients is just like it was before COVID. I mean, we take appropriate precautions. The staff and patients and healthcare givers and family members are masked, and we take every effort to distance and to put people in rooms immediately. But I think the general engagement of the family with the care of their loved ones is maintained, which is critical.
Absolutely. And I can just share insight as a former caregiver that I know that the information in part, I was the one to absorb a lot of it. So I think it's so important and critical that Siteman is allowing the care of the person and the patient through the family, because otherwise that information disseminated is lost. So kudos to Siteman for that. So moving on a little bit, the news is busy these days, and there's a lot happening in our world, especially as it comes to controversy related to the potential treatment of COVID-19. One of the drugs that we've heard a lot about is hydrochloroquine, sometimes in combination with other drugs, sometimes on its own. Dr. Fields, can you give us an overview of where the medical research stands on those potential treatments, including vaccines to date?
Yeah, I mean, I think we're sort of at an exciting time in the sense of there's a lot of potential, both vaccine and non-vaccine treatments. I think what everybody would agree on is that where the vaccines are now is there's a number of candidates that are now in more advanced clinical trials to really see if they work, that have been shown to be safe. And so now it's a question of testing large numbers of patients that may be in higher risk situations, because you need to compare a group to be able to say that people were exposed and one group got it and one group didn't based on the vaccine. And I think the timeline for that is still months away from something that might be approved and then manufactured to a scale where people would be getting it regularly. I think at least right now, the two most exciting things in my mind are the advances in testing and the advances in other therapeutics, many of which are being developed or studied here at WashU, and that includes plasma from patients as treatments. That includes some other drugs that have been looked at in other inflammatory conditions that are being tested now in clinical trials. And then I think we've learned how to use some other more common drugs like steroids that have been shown to be effective in the right situations that are making people who may be hospitalized and sick, less sick and less chance of having to go on a ventilator and dying, which is why big picture, I think we're seeing the positivity rate may be high and we still are seeing cases, but not the same sick cases, as well as the fact that we're initially had a lot of people from nursing homes and high-risk populations getting sick and of course, unfortunately dying. So we're getting a little ahead of that. One of the more exciting things that we've heard about nationally and is being developed here at the Genome Institute at WashU is this rapid saliva test for COVID. And although it's a test, it's not a therapeutic. What I think it may allow, because it's a rapid test that you could get back in 15 minutes or so. Think of it kind of like a pregnancy test for COVID, but you just sort of spit in this container and you get a result back. And it's cheap, you know, it's a couple dollars a pop. So if you're able to do that on a large scale, it will really allow you, I think, to safely open schools, have sporting events, dorms, things like that, because you could really not only contact trace, but identify cases of these asymptomatic cases quickly and earlier and without spread. So I mean, I think those are the big picture things that are on the exciting side of things, along with the news that Dr. DiPerzio had alluded to that really kind of came out in the past couple of days, is that people who are exposed probably have better immunity than we initially thought. We're not seeing people get reinfected, and there may even be a population of people that have immunity to COVID-19 because of their exposure to other related coronaviruses. So some optimistic things amidst a lot of potential things that may not work or have worked. Hydroxychloroquine, for example, we just don't have a role for it yet that's been well tested. There have been some other supplements and things, oleander, and some people pushing some things that really have no data for them. So there's a lot in the news, but the things I had mentioned, I think, are the most exciting.
Yeah, there is a lot of exciting things happening, which is great and is always being shared in the news. But one thing still that remains a challenge for us is testing. So Dr. James, when it comes to testing, if we think we need to be tested, what's the best way to seek a test? What's the best kind of test to request? And what kind of direction can you give those who feel that they may need a test to see if they are positive for COVID-19?
Yeah, I mean, I think what's really exciting are the saliva tests and the more rapid tests that are on the horizon that'll make testing a little less unpleasant and a lot faster than having to take a test and then go isolate at home and wait however long to find out. I think the best way to get tested is if you have a physician to call your doctor's office and get a recommendation from them about getting tested. If you live in St. Louis City, the federally qualified health centers are offering testing. If you live in the county, there's in St. Louis County, there's a number of places who are offering testing, and you can go to sdlcorona.com and find a testing location that's close to your house. But if you have a doctor, I think that's the first place to start, is call your doctor's office, talk about what your symptoms or what your exposures are, and find out the best way to move ahead. But it'll, as Dr. Fields said, as we get more rapid and easier to take tests, we'll be able to kind of identify people sooner and reduce the transmission.
Thank you. So Dr. DiPerzio, can we talk a little bit about vaccines and progress that is being made? Any updates to the proposed COVID-19 vaccines that are being studied now, and what's safe for those with a cancer diagnosis?
Yeah, so the vaccine world is ever changing. There's, at last look by me, there were, I don't know, something like 126 or 130 or so preclinical studies going on for vaccines. And right now, there's about 26 vaccine trials in phase 1 and 6 that are already in phase 3 clinical trials. So the vaccines they come in different sizes, shapes, and flavors. Some of them actually use disabled coronavirus, COVID-19 virus, as their substrate. Some vaccines use the RNA. So the virus is an RNA virus, and so the RNA of the virus encodes certain proteins which comprise its viral envelope, if you will, and those viral proteins are they become proteins that one can make an immune response to, and these are the so-called spike proteins. And so several of the vaccine trials use RNA. For instance, Pfizer has one. Moderna is the classic one. They're in phase 3 studies now, where the RNA actually encodes a spike protein, which is then used as an antigen or an immunogen to induce an immune response. And the vaccine that's probably the furthest along is the AstraZeneca University of Oxford vaccine, which is in phase 3 trials. They've already committed to providing more than 2 billion doses globally to, if it's effective, to treat the general world's population if this is an effective vaccine. So that trial uses a modified adenovirus. And so this is another virus that we often get infected with. And actually, many of the adenoviruses that we normally get infected with are very immunogenic. And so they induce strong immune responses, both for B cells and for T cells. And so those adenoviruses have been modified to produce some of the COVID-19 spike proteins. So you can imagine an adenovirus, which normally causes very mild disease or no disease, but is very immunogenic, which is now also expressing these COVID-19 spike proteins, which the body can then see and make an immune response to both B cells and T cells. And so that trial is ongoing, and there's both patients in the United States, but mostly in Europe, who have been treated. And the trial is set to enroll about 1,000 patients. So it's and then there are finally some interesting volunteer vaccine trials, and that patients would actually get immunized with modified virus that can actually potentially cause disease. But this is the best way to determine the extent of antibody production and T cell responses in the general population. So there's everything under the sun going on. There's and there are new ones that pop up every day, and there are a number of DNA vaccines as well. But there are 6 that are in phase 3 clinical trials, and probably the first readouts will be from the Moderna and from the University of Oxford study. The readouts will be probably in November or December for the first level of immunization. That would be 3 to 4 months after vaccination. I should also say that there's a consortium of institutions that are participating in these studies, and they're organized in part through the NIH. And so Washington University is one of those collaborating institutions, as is St. Louis University, and they're collaborating together to enhance vaccinations of patients in the St. Louis area. And they've committed to vaccinate about 3,000 or 4,000 patients in the area with various vaccines through the NIH.
Thank you. So our next question today is for, and it's very timely as we are heading into back to school. Dr. Clever Collins, let's talk a little bit about the children who will be going to an in-person school. Obviously, parents are making plans and planning accordingly, but what types of precautions should kids be taking personally, as well as families be taking for their children, either preparing for school or returning home after a day in a school setting?
Okay. Well, I went to the CDC and looked up a few things, and the list is very extensive, but some of the things that kind of stood out to me as a parent and what has been talked about, we all talk about the mask. Want to make sure you label your mask so that your mask doesn't get mixed up with your best friend when you're running around. They do say, that We need to encourage appropriate hand washing technique and washing hands consistently throughout the day. One of the things that was recommended is that you have your own hand sanitizer so that you can sanitize throughout the day as well. Try not to share objects. And then the social responsibility, you check in every day. You check your child and make sure that they're not having fevers or displaying other symptoms. And if they are, then you should keep them home. You shouldn't just try to cover it up with Tylenol and send them on. Make sure your child is up to date with their vaccinations and flu shot, because we know that the coronavirus has a lot of flu-like symptoms. So you want to make sure that that's not a confounder for any symptoms that you may be having. Develop daily routines for before and after, you know, whether that be packing your lunch or packing your hand sanitizer, making sure you're masked and you have additional masks in case the mask that you're wearing gets soiled. You want to have that backup mask for school. And then one of the things is that, you know, in public places, water fountains have been shut down. So want to know what your school's plan is for providing water to the kids. You might have to take your own water bottle and keep up with that. So that is of concern. And then I think being very familiar with your school's plans for how they're going to communicate about the COVID virus and any changes that may be happening in their plans for in-person versus having to move to a virtual format is also recommended. Carpooling, if you can, try to make sure you carpool with the same people each time. And there was this talk about pods, or having this small group of kids that the kids stay with throughout the day rather than interacting with large groups. If you can possibly, if there is a need to carpool with those people that you're going to be interacting throughout the day, that's a good idea. Or to just kind of limit the people that your child is exposed to on a daily basis until more widespread control of the virus is in effect.
A lot of good recommendations. I'm sure there's some parents on here that'll be watching this on repeat as they prepare for the upcoming week. So thank you for that. So we do have some questions. I'm sorry, that was our last question of the day. That was part of the presentation. So we'll now move into some Q&A. We do have some questions in our Zoom chat, as well as I am receiving some questions from our team via Facebook Live. So I'll just start to share those at this point in time, and really whoever feels best equipped, many or just one of you, feel free to answer any of those questions at this time. So the first question was about vaccines, and the statement was that they loved hearing about the various kinds of vaccines being studied. Would all of these likely be safe for those who are actively in cancer treatment, and do we know yet?
I guess I can answer that. The reality is that the first group of patients treated with these vaccines will likely not be cancer patients for a number of reasons. Number one, what is most important is the actual immune response to the vaccine. And so patients with cancer, especially patients who have been treated or have had some kind of therapy for their cancer, may be inherently immune suppressed. And so their responses to these vaccines may be, they may have an expected low rate of response. And we know that also because cancer patients actually get infected with the virus, and immunosuppressed patients do get infected, and they seem to shed virus particles for a very long period of time. But interestingly, those virus particles, even though they shed them for a long time, those patients don't seem to be able to pass it to other patients beyond a couple of weeks or 3 weeks. But the reality is that initially, cancer patients will not be the subject of any of these vaccine trials. Now, let's say there looks like there's going to be some encouraging results. So those patients that are immunosuppressed, that have cancer, will probably be the next group of patients that'll be studied in a separate study. So the vaccine, if there is an effective vaccine, and we hope that there are more than one effective vaccine, then those will be approved for the general population that are not immune suppressed. And then they'll have to do another study specifically in cancer patients to establish their safety, especially the vaccines that involve live attenuated viruses.
And I guess I'd echo all of that and say, and we've said this a number of times, you know, if you're a cancer patient actively undergoing treatment and there's a question about a new medication, or when it comes time a COVID vaccine, you know, your main point of contact is going to be your treating oncologist, who's going to tell you if it's safe to get that now or not. Because you may have very different patient populations. A patient that Dr. DiPerzio is taking care of with leukemia who's getting a bone marrow transplant and is very differently immunosuppressed than, say, a patient of mine who may have undergone a relatively straightforward outpatient surgery for a skin cancer. Could be very different answers to that question of, could I get a COVID vaccine or a flu shot or start on this medication? But I think that, you know, big picture too, the first thing we ask before we even ask if they're effective for these vaccines is, are they safe? And then the study. So we'll at least know big picture they're safe in non-immunosuppressed patients, and then we'll study them elsewhere.
Thank you. So while we're on the topic of vaccines, we've had a couple other vaccine related questions come through. So I just kind of want to stay on this thread. So one of the questions that came through was, after a vaccine is approved, and this might be a crystal ball question, how long until people can resume to normal life? And will enough people have to have it before it can really make a difference in public health?
That's a hard one, I think, to predict, but I guess, you know, what we'd all hope is that somehow when a successful vaccine comes along, that we can make it in large enough scale that people can get it quickly and that people will get it, which is a whole nother issue of patients or people, the general public, willing to take it, because enough people would have to get it for it to induce enough perfection to be able to go back to, you know, quote, life as usual. And how long it takes to get there is, I think, a factor of producing something on a mass scale, making sure that it works long term, and, you know, we may need things like booster shots for it, and then having enough people, you know, raise their hand, roll their shirt sleeve up, and get the vaccine for it to be a public health level success. I guess, Amy, I'd be curious to see what you thought from the public health level for that kind of vaccine effectiveness.
Yeah, and that number of percent vaccinated is different for different diseases. So there's, you know, you might have heard about herd immunity in the news way back when this all started in March and April. But the whole idea of that, as Ryan, you just said, is you want enough people to become immune and get the vaccine that reduces your likelihood of running into somebody who is infected, and reduces the chance that that infected person has people around them to transmit it to. So the idea of vaccine is also to protect the vulnerable people who can't get it. It protects us, it protects our neighbors, but it protects people who might not be able to get the vaccine, just because there's going to be fewer people around to transmit disease.
Anyone else want to jump in before I move on to the next question?
I might add one more thing, and that is, you know, Amy mentioned herd immunity, and, you know, what you read is that, you know, in order to really develop effective herd immunity, about 60 to 70% of the population will have to have immunity, so that the chance of bumping into somebody that's infected is so low that these rapid transmissions in the society is going to be limited. But I just, you know, I think that there's a certain level of herd immunity that's developing right now, and it will probably continue as long as the virus is in our society. You know, and this is from natural infections, most of which are asymptomatic. So there'll be a lot of herd immunity over time that'll develop from these natural infections that don't cause disease. And then the vaccines will actually enhance that. So the number of people that you actually have to vaccinate to get to that 60 to 70% number in a year or two might be many fewer than you think.
Okay, so The next question is about community resources. Do we recommend one specific resource to find accurate, up-to-date information on the virus, mainly how it spreads, what is safe, what is not safe, and where do we go to learn more?
I would do what Dr. Glover Collins did and go to the CDC as a place to find scientific evidence, and but also, the county Department of Health, the city Department of Health has links and information on their websites, as do the state departments of health. There's a lot of odd stuff out there. So.
There is a lot of information out there, and a lot of information that's come out about what is safe to do and not safe to do. So one of the questions was about being outside versus being inside. So this comes from a pedal staffer who also is an avid cyclist, who's wondering about being active outside as well as gathering with family in a backyard and staying apart. What are options when we have to move inside, when colder weather comes and we still want to be with our families? How do we engage when we're told, outside is safest?
Well, I think this kind of comes back to the point where the masking is really important. That, it might be uncomfortable, but if there is the risk of transmission, then everybody needs to wear a mask when you have to be in closer quarters. Of course, being outside allows you to be further apart so that you could potentially remove your mask. But I think that's when the masking will become very important, is when you have to go inside. Also, hand washing.
Yeah, I'd echo that. I mean, I think when daylight savings reverses and it gets a little colder, I think we're going to be challenged to safely continue doing a lot of things that we are doing outside now, which are, I think, infinitely safer when you're outdoors and there's a breeze and the ventilation is better. A lot of places, including schools, are trying to upgrade their ventilation and their filtering systems and things to make that a better reality. But once it gets a little colder and we are back inside, I think, like Catherine said, wearing a mask, hand washing, and staying apart, and sad to say, but limiting that as much as we can, it would be challenging. But until there's really an effective vaccine and things, I think it's going to be hard to do a lot of the things that we were doing in the past, short of continuing to do them outside through some of the cooler weather. And I'm sure there'll be a run on those propane tank outdoor heaters pretty soon as people start to think about that a little more. It'll be like the toilet paper run of April and March.
I just wanted to add to that is that you're really only as safe as the people around you. So when you do get a large group together and you've been safe, but do you know that everybody else in that group is being as cautious? Because I think a lot of those stories you see about it getting transmitted among families is that there was one person who didn't realize they were potentially infectious. And that's when it can happen.
Absolutely. Well, those are all the questions that have come through today. I think we have a lot of work to do, but it sounds like a lot of work is being done. I think the most important thing that we've heard today is, when in doubt, reach out, ask your doctor, wash your hands, wear a mask, stay safe, and just look out for community and make the best decisions that make sense for you and your family. And for those with a cancer diagnosis, obviously your oncologist is the first stop if you have any questions. Before we depart today, I'd like to thank our panelists, Dr. Ryan Fields, Dr. John DiPergio, Dr. Catherine Glover Collins, and Dr. Amy James for joining us for this session about COVID and cancer. Are we making progress? Stay safe, everyone, and have a great afternoon. Thank you so much.
Thank you.
Thank you.
Thank you.